Welcome back to the Pro PA podcast. I'm your host, Prof G, and you're listening to another episode of our MSK101 series, where we break down the most high-yield musculoskeletal and rheumatologic topics straight from the PANCE blueprint. In this episode, we'll tackle polymyalgia rheumatica, a commonly tested and clinically important inflammatory condition, especially in older adults. We'll cover how to recognize it, how it's related to other conditions like giant cell arteritis, and what treatment looks like. Let's dive in. Did you know that up to 50% of patients with giant cell arteritis also have polymyalgia rheumatica, and vice versa? Recognizing one might help you catch the other before complications arise. All right, so first let's look at the kinder patho. What is polymyalgia rheumatica? Well, polymyalgia rheumatica, or PMR, is an inflammatory condition of unknown etiology that causes pain and stiffness in the proximal muscles, especially the shoulders, neck, and hips. Despite how it feels, it's not a true myopathy. Muscle strength is preserved, and the inflammation is primarily around the bursae and the joints, not the muscle fibers. It almost exclusively affects adults over 50, with the highest incidence in those over 70, and it's more common in women and in Northern European populations. All right, so next let's look at the clinical presentation. So, most often patients exhibit bilateral shoulder pain and stiffness. This is by far the most common presentation. Also common are hip and neck stiffness. Symptoms are worse in the morning and improve throughout the day. Patients often describe difficulty getting out of bed, brushing the hair, or rising from chairs. No significant muscle weakness, just pain and stiffness. And they also exhibit systemic symptoms like fatigue, low-grade fever, and weight loss. Check for coexisting symptoms of giant cell arteritis like headache, jaw claudication, and vision changes. All right, now let's look at the workup and how to diagnose. So, it is a clinical diagnosis and it's supported by lab work. You're going to notice an elevated ESR and CRP. These are the Hallmark findings. And we often see that the ESR is above 40 and sometimes above 100. These patients also have a normal creatine kinase or CK, and this helps distinguish it from myopathies. They also have normal muscle strength on physical exam, and no specific autoantibodies required for this diagnosis. Imaging like ultrasounds or MRIs of shoulders and hips may show bursitis or synovitis, but not always needed. All right, now let's look at the treatment. So, the treatment of choice is going to be low dose corticosteroids, most often prednisone, like 10 to 20 milligrams a day, and this is going to be the mainstay of treatment. You often see a dramatic response within 24 to 72 hours. You'll definitely want to taper the steroids slowly over several months and monitor the ESR and CRP to guide the taper and to detect relapse. If symptoms persist or recur during the taper, you might have to increase the dose slightly before resuming the taper. You also want to screen for GCA symptoms regularly. PMR and GCA often coexist. All right, now let's look at the book med versus the street med. So, book med is going to show you a patient over 50 who wakes up with shoulder and hip stiffness. ESR is going to be sky high. You're going to want to start steroids and taper slowly. Very simple. However, the street med, the patient might just say, "Doc, I feel stiff and I feel tired all the time, and I think it's just aging." And without dramatic weakness or joint swelling, it can be brushed off as something like osteoarthritis or just general fatigue. You have to ask the right questions and consider PMR in anyone over 50 with new bilateral pain and stiffness. All right, some clinical pearls to wrap things up. PMR equals proximal pain and preserved strength. Morning stiffness usually lasts more than 30 minutes and it's a classic clue. Rapid response to steroids is both diagnostic and therapeutic. Normal CK, elevated ESR, and CRP are key to differentiating it from polymyositis. And always assess for temporal arteritis. Don't miss GCA. All right, now it's time to do some practice questions. Question 1. A 72-year-old woman presents with bilateral shoulder and hip pain and stiffness that's worse in the morning. She reports difficulty rising from bed but denies muscle weakness. Her ESR is 85. What's the next best step in management? Is it A, high-dose prednisone, B, methotrexate, C, low-dose prednisone, or D, naproxen? I'll give you a few seconds. If you answered C, you are correct. It is low-dose prednisone. PMR responds well to low-dose corticosteroids, often within days. Question 2. Which of the following is most consistent with polymyalgia rheumatica? Is it A, an elevated CK and proximal muscle weakness, B, a positive ANA and symmetric joint swelling, C, normal strength and elevated ESR, or D, morning stiffness and distal joint pain? I'll give you a few seconds. The answer, C, normal strength and elevated ESR. Remember, pain and stiffness without weakness plus an elevated ESR, this is what's going to point us to PMR. All right, some final thoughts. So polymyalgia rheumatica is one of those conditions you can't afford to miss in your older patients. Know the red flags, listen for those can't lift my arms complaints, and think ESR plus steroids. Thanks for tuning into this MSK101 Clinical Medicine Brief. Be sure to tune in next time where we will cover more rheumatologic conditions straight from your PANCE blueprint. And as always, this is the Pro PA podcast, where future pros in medicine are made. See you in the next one.